require a lot of strenuous activity for them to start feeling that shortness of breath, which is more where we want to see these patients. When you're looking at your CAT score, this is just a COPD assessment test. So if you have a patient who has COPD, this is just how you're going to say, hey, how is the severity of this, how is this interfering with their day-to-day? And I have this listed because we're going to talk about this when we're saying how we're going to treat our patient. So you're going to see either an MMRC score or you will see a CAT score. Remember, your MMRC score, the worse that it is, so like the higher the number, the worse that they are. And then the same thing when we're talking about their CAT scores, which I'll show you a little bit more when we get to those. So a big thing that I told you that we're going to talk about is smoking cessation. When you have anybody who is coming in and they have asthma, if you have anybody who is coming in and they have COPD, your job is going to try to convince them to smoke. To not smoke. To not smoke.
The cigarette company's got to.
Don't recommend smoking. What you will see, like I have a friend, her mom has COPD and she's on oxygen. She will turn off and disconnect her oxygen tank to go outside and still smoke a cigarette and come back and put herself back on. Sometimes she won't even turn the thing off and I am like, ma'am, you cannot do these things, okay? So like, make sure that you understand this is the hardest part for these patients who have COPD and asthma, especially if they do like to smoke, is for you to get them to stop. And sometimes you don't look at it and be like, okay, it's your lungs, like you can't breathe. Don't give up on them. Try every single visit, just remind them. Also, we have clinical pharmacists who work on just trying to do smoking cessation. So they will follow that patient for you if you don't have time or if you don't want to keep trying to convince them to take care of themselves. You can also refer them to the clinical pharmacist, and the clinical pharmacist can also follow that, put them on the medications that they're supposed to be on, change the doses of those medications that they're supposed to be on, okay? So remember, this is a big part of trying to make them well again. These are all of our different medications that you're going to see that we use when we're talking about COPD. You're also going to hear a lot about GINA, which is a guideline that we typically use when we're talking about asthma, when we talk about some of our COPD things. So we're going to go through and look at some of the different medications that we have. So this is just giving you essentially a summary of all of the drugs that we're going to talk about. So we're going to go through some of these we don't get into, like these mucolytic agents. Some of this we won't really talk about a whole bunch. But when you're talking about your SABAs and your SAMAs or your short-acting beta-2 agonist or your short-acting anticholinergic, you'll see that. We'll talk about LABAs and LAMAs, which are your long-acting beta-2 agonists or your long-acting anticholinergic agonists. We'll talk about different types of inhalers. So this is just telling you some of those abbreviations that you'll see. When we talk about these medications, if you do prescribe something that needs to go into a nebulizer, you need to make sure that there is a nebulizer machine that you have ordered. We do not carry those in the pharmacy. That they will have to go to like a medical supply store for. There's several different ways for you to get those. So don't get them like something that needs to be nebulized and they don't have a nebulizer machine. So make sure that they have the nebulizer machine because then they can't use the medication that you're going to prescribe. We have some oral options. You don't typically see those. For the most part, in these patients, you're going to see a nebulizer or you're going to see an inhaler being used. We have injections for our patients where we're doing not so great or they're very resistant to some of our treatments. And then you'll see some different durations that we'll talk about as to why we classify something as being short-acting versus long-acting. All right. We have what's called our bronchodilator. So this is where your meds start to really kick in, and this is where your exam starts to kind of kick in and get very heavy. Well, actually, on this slide, because that's your summary slide of all the stuff. So when we talk about bronchodilators, essentially what they're doing is in the name, right? It's trying to help me reduce those symptoms that that patient is having from that shortness of breath, right? Because I told you they had limited airflow. So I'm trying to dilate their bronchioles so that they can breathe better. I have 3 drugs that fall into the class of being a bronchodilator. I have my beta-2 agonist, my anticholinergics, and I have where I can sometimes take a combination of both of those medications and put them into one inhaler. So you'll see where we are trying to, again, bronchodilate. I'm trying to open that patient up so that they can breathe better. When you look at this, just make sure that you're trying to say, hey, how are you responding from this treatment? Is this treatment effective for you? How often are you having to use your rescue inhaler because you're having an exacerbation? An exacerbation is essentially where they have a flare of like, oh my gosh, I can't breathe. They feel their chest kind of tightening up. And so they have what's called an exacerbation, where they have that shortness of breath kind of kick in, and then they are needing immediate relief to kind of open those bronchioles back up, stop that spasm from happening so that they can breathe again, okay? So when you're looking at this, just remember your bronchodilators are trying to relax the bronchioles. So again, you have your beta-2 agonists, and we have our anticholinergics, and sometimes you'll see where these are going to be used in combination with each other. Mechanism of actions are listed here. We've talked about beta-2 adrenergic agonists several times. We talked about them last semester. And so talking about them again in the sense of COPD specifically, and we'll talk about them again when we're looking at asthma. But what we're doing is increasing the cyclic AMP, so that way I can have those smooth muscles relax, right? I'm dilating so that I can relax, and now I can take in more air, okay? When I'm looking at my anticholinergics, with this, again, blocking those muscarinic receptors. We've seen this before, right, with our acetylcholine. And then again, you're trying to say, hey, I don't want that bronchoconstriction to happen. Because I am an antagonist, I'm an anticholinergic. Because I am an antagonist, I'm trying to stop that receptor from being activated and constricting. So if I can block it and I can stop the constricting, I am dilating, okay? So bronchodilators. When we look at our drugs that we have for this, we have, again, the beta-2 agonists. So when you look at these, remember when we talked about our beta blockers, they were all LOL, right? So these are alls. So all of these you see, they are, except for your terbutaline, and we'll talk about terbutaline because that's one that's kind of like a, but these are all ROL at the end, okay? So levalbuterol, albuterol, and terbutaline are your short-acting. We also call these SABAs. And then you have your long-acting, which is your alpha-mortarol, formoterol, salmeterol, and olodaterol, and then your indacterol. Your indacterol is a long-acting, but this is like an ultra-long-acting drug, so it lasts for a very, very long period of time. When you're looking at this, this is saying, hey, is it an inhaler? Is it a nebulizer? Is there an oral option, like a tablet that this comes in? Hey, can I give this in an injectable form? What we're going to focus on is going to be my inhaler and my nebulizer route, right? So when you are prescribing this medication to one of your patients, you will be typically choosing to either give them an inhaler or to have them nebulize that medication for themselves. For the most part, we like to use inhalers because they're easier to transport, less work, okay? We'll talk about these as we go. I won't ask you like, hey, is formoterol a DPI kind of thing? I will tell you if something is a DPI, and when we go over the different ways that these inhalers are made, you'll see that some of them you have to have the capacity to be able to breathe to get that medication into your lungs. So if somebody has very restricted airways, which it could be likely in one of your COPD patients, then hey, maybe that type of inhaler is not a good option for them. Maybe I need to give them something else that's like an HFA or something that's going to be forcefully inserted or distributed to their lungs. So when we get to that portion, I'll talk to you about that. I want you to focus on SABAs and LABAs, short-acting, long-acting. These are beta agonists, right? So short-acting beta agonists, long-acting beta agonists, right? SABAs, LABAs. So when we talk about terbutaline, this one, you're not going to see us use this a lot anymore, really. Doesn't really, when we talk about this drug class overall, these aren't helping with the underlying issue that we're talking about in COPD, right? It's not addressing any inflammation that patient is having. It's just trying to help them breathe, okay? It's just bronchodilating. It is not doing anything with the issue that we have at hand. So here with your terbutaline, most of the time you'll see this used in OB sometimes now, but not very common. So just understand that it does fall under your beta-2 agonist class, but not something that you'll probably be prescribing. The more famous one and the more popular one that we prescribe is going to be your albuterol that we use as a rescue inhaler. And then down here, you see all of your other options. I want you to pay attention to this because these you can use when we're talking about COPD. When we get to asthma, some of these medications you can't use in asthma. So just pay attention to that switch that you're going to see when we do get to asthma, okay? So COPD, beta-2 agonist use. Again, your clinical use, most of the time, especially if we're talking about a SABA, these are going to be our short-acting, very quick onset. We're using these because my patient has an exacerbation. They can't breathe and I'm trying to relieve that from them. The most common way, again, that we're prescribing this is going to be through that inhaler. And then making sure that if someone doesn't have a lot of exacerbations, they may not use that SABA very often, right? They're probably not using their inhaler very often. You need to make sure that the patient is checking to make sure it's not expired, right? Because if I don't use something for a very long period of time, it may expire, and then I need it, and now the drug may not work. And in an exacerbation, they need that inhaler to work, because if it doesn't, they can die, okay? So it will become a medical emergency if they don't have it. So that's the big thing that I always counsel the patients on, is to, especially if they're not using it a lot, to make sure that it is not expired. The other thing is, if you see that your person is using their SABA a lot, then that should tell you, hey, my maintenance therapy isn't great. I probably need to improve what I'm giving them on a daily basis if they're having to use their SABA or their rescue inhaler frequently, right? So the more that I'm telling you I'm using my SABA, the more concerned you are in trying to adjust my medication regimen to where I don't have to reach for it, right? Because I'm trying to make sure that they don't have that limited airflow. And if they are saying that they're having a lot of exacerbation, that means that they're not well managed with some of our other meds that we'll talk about for management. So we can put them on a LABA, we can put them on a LAMA. Those are the ones that we typically see them managed on. So that may mean, hey, I probably have to increase the frequency or the dose of one of those inhalers so that they're not using their SABA so much. So that's what this means by monitor the use of the SABA to determine if control is adequate, or identify the need to step up their treatment if we need to be more aggressive with their maintenance treatment, okay? Again, here are your products listed here. And then looking at your LABA, this is again kind of where we're talking about a standardized maintenance type of thing where we're using these medications. More often than not, you're going to see these a lot in our asthma patients, and then you see all of the products that are listed here. Remember, I told you these are your long-acting, but your ultra-long was going to be your Indacterol, and then there's two different formulations that they have of it, where you can put it either in the inhaler to breathe it, or they have the capsule formulation of it. So just in some of these, when you see capsule, doesn't necessarily mean that they're swallowing it. Some of our inhalers, they have capsules, and when they click it to that to take that dose, it will puncture a hole in it for them to get the medication. So that's also how you can see capsules on this a lot. All right, this is what I was talking to you guys about when I was saying, I was telling you, you see all of the different types of inhalers. So you'll see the generic name, and then you'll see FHA, well, that's the old one. You'll see HFA, you'll see DPI, SMI. We have all of these different routes in which we can give them. These are all inhalers except for the nebulizer, okay? The nebulizer is that actual machine that you'll see where people have, like for the kids especially, they're like cute little things now. They'll make them into monkeys or different little animals, and then they have to have that mask that's connected to it, and it's kind of loud. They turn it on, and it'll nebulize that medication through the mask onto their, so that whenever they breathe, they're breathing in the medication. So it's a mask that they have to sit there and they actually strap onto their face. It takes maybe 15 minutes or so for a full vial to get nebulized to that child. So when we're looking at our HFA, this is the most common one. Depending on what type of inhaler you prescribe to a patient, you may or may not need to use a spacer. Also, depending on your patient's hand-eye coordination, you may or may not need to use a spacer. So what a spacer is it's like an extra little chamber, and I have a picture of that that'll come up. I had one that I was going to bring in, and my kids have been playing music on it, and I don't know where it is. So with that, you take them, and it's literally like a tube, and then you would put the inhaler on one end of it, and there's another picture of it at the end of this lecture. But you put the inhaler on one end of it, and then it keeps the the medication dispensed in that tube, in that circular tube, so that they have a longer time to breathe it in, and then they just take normal breaths, and all the medication is stuck in that chamber. Okay, so they're very good options for some people who will tell you like, hey, I don't have very good hand-eye coordination, and I'm not going to be able to get that puff in when I take my breath. You can also use a spacer. If you're doing an inhaled corticosteroid, it's also good to use a spacer so that we can decrease the risk of infection. So we'll talk about some of that. Your dry powder inhaler, so again, I told you how sometimes you'll see capsules. So it'll have the medication inside the capsule. Whenever they turn it, it pokes a hole, like the inhaler will poke a hole into that capsule. But the patient has to be able to take a deep enough breath to inhale and disturb that powder to where it can get into their lungs. So if I'm not able to take a deep breath, this medication does absolutely nothing for me. So if you see sometimes what we were seeing in the ED was that people were being prescribed inhalers that were DPIs who had very restricted airflow, and they couldn't take in a deep breath. So they were using their inhaler how they were supposed to, but the medication was really just in the inhaler because they couldn't disturb that powder enough to get it into their lungs. So the dose that they were getting was like a fraction of what they were supposed to be getting. So sometimes we were decreasing hospitalizations by just changing the formulation, putting them on an HFA or an SMI instead. So your SMIs, these are newer, these cost a lot more money than your HFAs. So these are soft mist inhalers, and essentially what happens is you're holding this differently than you would hold some of the other inhalers. So this is like a soft mist inhaler that you can see. And so you hold it horizontally, and they have like a twister on them, and they kind of just twist it, and it does a soft mist in their mouth for them instead of an inhaler where you're kind of holding it up. It's like an L shape, and you're holding it up and you press down, and then it'll spray the medication into your mouth. So this one, they're holding it differently, and then they twist it, and it puts the medication in their mouth for them. And we already talked about the nebulizers. So your nebulizer, more likely for your children or somebody who says, none of these work for me. And out of all of these, your HFA is the most common one. Your DPI, you have to take a deep breath for your DPI. And then your soft mist inhaler, you're going to spend some money, okay? It costs more expensive. All right, mechanism, we've already talked about this. Our clinical uses as to how I can use this. Asthma, COPD, hyperkalemia. When we talk about hyperkalemia with this is just talking about how sometimes your beta receptors, if they get stimulated, they can make the movement of your potassium ions go into the cell, so therefore you can see a decrease in the potassium blood levels occur. So you'll see us sometimes use our beta-2 agonists for that purpose as well, okay? So mechanism is the same thing we saw previously. Remember, they're bronchodilators, increasing those CAMP levels so that you can have relaxation. Adverse effects, we've seen these before, right? Like these are the same things that we were talking about with like some of our beta drugs, okay? So tachycardia, hyperglycemia, understanding that with this, your diabetic patients, yes, you are concerned, but it doesn't mean that you don't have to not give them these medications, right? I'm going to monitor them because I'm likely to see that those glucose levels are going to go up. Respiratory tract infections, that's also by way of their disease state, right? I have COPD, I'm probably also likely more prone to be having those upper respiratory tract infections, and then the medications as well. Also, some people will place their inhalers in really nasty places. They will have them in their purse, they'll have them on the floor of their car, they will have them in the kid's backpack, like all over, and sometimes people don't wash out those mouthpieces. If they're sick and they're using their inhaler, they will continue to use that inhaler and not clean it. So make sure that you can tell them sometimes, like, hey, if you want to disconnect that plastic piece of your inhaler and wash it off, you can, okay? And then looking at this, we were talking about may increase the risk of asthma-related death. This goes back to, is their SABA expired or not, right? Because if it's expired, it's not going to work. Also, if you're talking about an exacerbation and they're trying to use a long-acting beta agonist, it may not work quick enough, right? It's taking too long. We do have some that have a short onset, but still we don't use them when we're talking about rescuing in a SABA, like in an exacerbation situation. So anytime you see exacerbation, you should always think of SABA. You should never be picking a LABA for an exacerbation, right? And then looking at your interactions, again, if there's any type of drug that they can have that have those adrenergic effects or like those sympathomimetic effects, we want to watch out for that, because I already told you that this speeds everything up, right? I have tachycardia, I have those tremors. We talked about how the hypokalemia occurs, right? Remember that shift? So you can kind of remember that with these, because that's also one of the uses that I have for it. And then looking at your beta blockers, again, if I have an agonist with a blocker, they're antagonizing each other. So just understand that they won't work with each other. And then pregnancy, it's okay for us to use them. You will see these used in our pregnant patients. Just make sure that they're not having to use them a lot. Our anticholinergic bronchodilators that we have. So remember, we're still talking about bronchodilators. So we talked about our beta-2 agonists. Now we're going to talk about our anticholinergic medications. Again, antagonizing the effect on those muscarinic receptors to our acetylcholine is what that mechanism of action is doing. You also see that this is increasing our calcium levels inside of the cell as well, okay? When we look at our medications that we have, now we still have short-acting and long-acting, but these are muscarinic antagonists that you have, right? So you see your short-acting, so your SAMAs, and then you have your long-acting, which are your LAMAs. So the one that you have for your short-acting is your ipratropium. It's isolated, it's all by itself. And then you have your long-acting, as all of our other medications, you see that they end in -ium, right? So you have your eclidinum, your glycopyrronium, your tiotropium, and your muclidium. Okay, when we talk about this, the one that you see used the most is going to be your tiotropium or your Spiriva, which is an inhaler. Very good option, and that's the one that we typically that you guys will be prescribing. But remember that that is one of your LAMAs, and your ipratropium is the SAMA that is isolated. It's all by itself. It's the only one. Okay. Looking at our mechanisms, remember that ipratropium, SAMA. Okay. Our use, you can see that I'm using this for COPD. We'll talk about how we can have, because it is a short-acting drug, I can use this one also for exacerbations. And then you see that I can add on a LABA. I can add on other medications to also have it as maintenance treatment for my patients who have COPD, and we'll look at that algorithm in a little bit. Pregnancy, you see that it's all right. And then my adverse effects, just think about anticholinergic effects, right? So the higher the dose or the more frequently that they use this, the more likely you are to see those anticholinergic effects occur, right? Yes, it's going to the site that I need it to go to, which is the lungs, but if I have too much or a very, very high dose, I'm more likely to see those systemic effects occur. You see the paradoxical bronchospasm occurring. Hopefully that does not happen to a person, especially when they're using it as a rescue inhaler. So just make sure that you're watching out for that, and ask your patient, hey, have you ever used your inhaler and instead of feeling relief, you felt like a chest tightness? Because that's what the paradoxical bronchospasm is. And then the sensitivity is just saying they're sensitive to that medication, right? They have a reaction to the medication, which could happen really with anything. Tiotropium or your Spiriva, just remember your Tio, he's old. Your uncle is an old man, right? So tiotropium is one of our LAMAs, long-acting. You see that I can use this as my maintenance therapy, which is most of the time how you're going to see this used. Depending on how bad the patient's symptoms are, they can either use it once or twice a day, okay? So it's not like it's something that interferes with their daily function a lot, or like interrupts their daily activities a lot, because again, if I'm not poorly controlled, I'm likely only using this one time a day. If my symptoms are very, very bad, then you'll see where I'm using it probably twice a day. Because it is a long-acting, you see that I'm not using it in my patients who are having an exacerbation, right? That's that emergent quick situation. So anytime that I see exacerbation, I'm not thinking anything long-acting, I'm only thinking something short-acting. So that's why you see that this is not for your bronchospasms that they have. Pregnancy, probably okay for us to use it, but you see that we don't have a lot of research, so this is one of those question marks. So when we see a lot of question marks like that, y'all know I don't really like to ask you that about pregnancy. Adverse effects, again, same thing that we saw previously with our ipratropium, you are seeing now here with your tiotropium, and then your drug interactions, understanding that if you have another anticholinergic that I'm adding on, right, additive effects. Okay, so same exact slide, just again pointing to the fact that this one is a LAMA, and then the pregnancy is more questionable whenever you're looking at this, and that we're not using it in an exacerbation. This is more so a maintenance drug. Okay. Your long-acting are more maintenance. And then this is what I was telling you about with the combination products that you can see, right? So what they did was they took ASABA, which is, what drug class does ASABA fall into? Beta-2 agonist, right? And then they took a SAMA, which is, what does SAMA stand for? The anticholinergic, right? So my anti-muscarinic antagonist. And they added them together. So if I have a person who is on both of these, now I have two different ways in which I'm trying to attack and allow that bronchodilation to occur, right? To try to stop a bronchospasm. So here you see Combivent, or which is your albuterol with your ipratropium. Again, I would just expect you to know what it is composed of. So you know that this is a SABA, and you know that this is a SAMA, okay? I won't give you fake names. And then this one again, they combine two things. They combine my long-acting, so they combine my LABA and my LAMA. So now I have my combination products with these. So my LABAs are on this side, and then you have your LAMAs on the other side, okay? So same exact thing, just know what it is composed of, and then you'll be able to be like, oh, this is a combination product that I could potentially use. Inhaled corticosteroids. So when we talk about corticosteroids, and as you go through this lecture, make sure that you're paying attention to whether or not it is inhaled versus if it is systemic. Okay, because we're going to also talk about systemic corticosteroids being given in some of these conditions as well. So when you're looking at your inhaled corticosteroids, this is saved for your more severe patients who aren't very well controlled on a LABA or a LAMA, or in a case where you see increased eosinophils in some of our patients, and that would be a lab that you would get back. It will come and it will be elevated. Typically, we look at greater than 300 with those eosinophils, and we'll see that later. But this is like on the severe end of the spectrum, right? Because steroids, we don't want to give them for a long period of time. We'll talk about them this block. They're great medications. They work fantastic. But the issue is just the side effects, especially if you have somebody exposed to them for a very, very long period of time. Looking at the increased risk that you see, right? So I have more infections, which we've talked about. We talked about the thrush and different things that can happen with your patients, especially if they're using them for a long period of time. And then that withdrawal that can happen in some of our patients. We said, hey, we have to first make sure there's not HPA axis suppression whenever we taper them off of these medications. But not only that, I can also cause my person to have an exacerbation, which is what I've been trying to prevent the entire time. So this is something that you're trying to be careful with. They are good medications to use though. You see here that I can use my inhaled corticosteroid with my LABAs. So I have medications that are, again, being combined for that synergistic effect, and what studies have shown is using that combined version of this inhaled corticosteroids with the LABA has a better outcome than you using either of those alone, okay? So again, you're trying to improve that status of that patient, improve their lung function, and now you're tackling it from two different ways when you have on these two medications. And then reducing the exacerbations is very important. The idea behind the reduction in the exacerbations when you're talking about having an inhaled corticosteroid is because I'm also now dealing with the inflammation, right? Because our steroids decrease inflammation. So I can get that added benefit here because, hey, maybe they won't have as many exacerbations because I have on this inhaled corticosteroid, which is decreasing how much inflammation they have in their body. Looking at this, you see that we also have an increased risk for pneumonia, all these different types of things that we were talking about already over here. If somebody is on an inhaled corticosteroid, it's very important for you to counsel them on the use of this medication. They need to make sure that they're rinsing out their mouth and their mouthpiece of their inhaler after they take their inhalation, okay? If they do not do that, we have the candidiasis that we were already talking about that could occur. So they'll have essentially thrush on their tongue, and then you would use an antifungal to try to treat that condition for that patient, okay? So I want you to, I'm not gonna take you back to that time where you're tormented when you have to learn about antifungals. That was a great lecture. But I want you to know that candidiasis is what will happen if they don't, right, rinse out their mouth, and also if they continue to not rinse out that mouthpiece. So this is one of those medications that we can use where we say, hey, if you like, I can give you that spacer, okay, to use this medication with as well. So understand that if they do end up with the candidiasis, that you are going to need to treat it with an antifungal. So you need to know that an antifungal is what is used to treat that. Here are our combination products that you see. So you have your LABA and you have your inhaled corticosteroid. Again, making sure that your patient is washing off this mouthpiece after they use it. And what else do they need to rinse off? Their mouth, right? Rinse out their mouth, rinse off the mouthpiece, okay? Because that steroid just sitting there can cause a fungal infection. So again, you see which of these components are your LABAs, and then you see the other component as your inhaled corticosteroid. So your budesonide, your romedazole, fluticasone, these are your steroid portions of it, okay? So make sure that you're understanding that these are, again, our different inhalers that we have that are available. But I'm focused on you just understanding what is combined, right? A LABA with your inhaled corticosteroid. Some other medications that we have, we kind of already touched on this in the very beginning. They'll need to be on some oxygen. Just know the word oxygen is an option that they have. And then you also have theophylline or Theo24. So when we look at theophylline, just understand that this has that methylxanthine, which is kind of similar to or equivalent to caffeine. And something that we used to use a lot more a long time ago than us using it now. So this is never something that you're going to see us use as a first-line option for our patient. They're going to have failed everything else. I just want you to understand what your mechanism of action is here as well. So inhibiting that PDE to increase the concentration that we have of our CAMP. Okay, and then anytime you see an increase in CAMP, that means that now you have more relaxation. Okay, so that's all that this is saying. We're looking at our pros. It does give you somewhat of a bronchodilator effect, but it's not, again, our first-line medication that we would have. Also, with this, make sure that you understand that this is an oral medication. Most of the time when we're using it in an outpatient setting, it's oral, but we also have that IV option if the patient is inpatient at the time. But again, not something that we just reach for. And then you see all of the things that we don't love about it. Arrhythmias, convulsions, narrow therapeutic index means more issues for me as a provider, which is also why we just don't like to use them, right? So make sure that you know that it is something that exists, and it is something that you could potentially see, but that's going to be because like nothing else was working in this patient, and we tried to put them on something to see if it can manage, if we can manage them. Looking at your roflumilast or your Dilacept, again, another oral medication that you have, similar mechanism with that PDE4 being inhibited, so therefore I can decrease the amount of inflammation that somebody has because now I have increased my concentration of CAMP, which then leads to more smooth muscle relaxation, okay? So you see that this is all indirect. It's not like it's directly acting on that, right? It's just helping CAMP not be degraded. So this is kind of how we talked last semester about like indirect type of actions with some of our drugs. This is one of those indirect actions that we have to increase our CAMP. Contraindications, if somebody has liver impairment, if they're breastfeeding, this is a no. Your clinical uses for those very severe exacerbations, and you have already tried to treat them with a corticosteroid. If your patient has very severe COPD, this could also be something that you have on board for them. If they have very frequent exacerbations, another thing. So this is a big one for like, if you know that your patient is on their disease state has progressed by the time you're putting them on this. They're having a lot of exacerbations, they have a lot of airflow restrictions. And then when we talk about this role, right, it's trying to tell you like, yes, this is a medication that is available. Do we typically go to this medication often? Not really. okay? So it's an option that's out there for you. Y'all learn about this a little bit more whenever you're doing Pharm and see that it's not something that you're gonna, most of the time if somebody's on this, they had to get referred. Adverse effects, decreased appetite, weight loss, sleep disturbance are the bigger ones that you see here, and they're kind of, with the decreased appetite would lead to weight loss, right? So if you remember one, you kind of know the other, and then that sleep disturbance that you have. Again, if somebody has any issues with depression, and we'll talk about some medications like that when we get to smoking cessation, this is another one that we need to make sure that we watch out for. And then looking at our interactions, if somebody has a CYP inducer on board, could potentially interact with our PDE4 inhibitor, and then not recommended also with those inhibitors as well, okay? So lots of interactions, not something that we would love to take care of with our patient, okay? Several contraindications as well. They have to have great liver function, and they have to not be breastfed. Like this is, in most of the time, your patients who have COPD aren't in childbearing age, they're sometimes older, okay? Anti-infectives, just make sure that your patients have your vaccines, okay? I'm not gonna ask y'all about this. Just make sure that they're up to date on their vaccines. And then you're only using antibiotics in this situation for your patients who, depending on what the issue is as to why they have an exacerbation, you may have to use an antibiotic as well, okay? So just understand that that's something that's on board. Okay, we talked about Gina, and Gina is giving you your directions on how you're going to treat your patient. So we went over all of our medications that we have. Now we're going to talk about how do we help treat our patient who has COPD. So you have three different groups. We have group A, we have group B, and we have group E. So I like to say this is A, right? A, group A, group B, group E. If I am in group A, you see that I'm not, there's two ways that we're reading this, right? So we talk about the amount of exacerbations or hospitalizations that they have. That's what you're seeing along this axis. And then when we're talking about our CAT and our MMRC scores, which we talked about at the very beginning, this is like, hey, you're not so bad. Hey, I'm getting very, very bad. Okay, so this is talking about their symptoms, and this is talking about how often do I have a flare? Did I need to go to the hospital? Okay, so your MMRC 0 to 1, right? They're mild. Their CAT score is less than 10. They're mild. So the way that I try to remember this is I try to remember less than 2 here. And I try to remember less than 2 here, and then I'll tell you what I'm doing. Okay, so group A, I'm not that bad, right? This is like for your patients who are earlier on. They don't have a lot of exacerbations. They've never been in a hospital. I'm in group A. Just give me a bronchodilator, help me breathe, right? If I am in group B, you see I'm over 2 now with my MMRC. I'm over 10 with that CAT. I'm more inhibited in my daily activities, right? I'm telling you, hey, I can't get up and do certain things. It's a little bit more difficult for me. I'm complaining of things now. So now you have your LABA and your LAMA on board for this patient. Remember, if I can give them these things together, I said that my results could be a lot better, and I want to try to give people dual inhalers if I'm going to have them on dual treatment, because less is more, right? I'm going to be more compliant if you give me less things to take. So I don't want to give them a single inhaler that's a LABA and give them a single inhaler that's a LAMA and say, hey, take 1 puff of your LABA and then take another puff of your LAMA, and then we'll do that. If you give me 1 inhaler, I'm more likely to follow your directions, okay? And it's a little bit easier. So that's group B. Still, they have no hospitalization. They've only had maybe 1 exacerbation. Now, I have more than 2 or more exacerbations, or if I've had to go to the hospital at any point, I'm in group E. You're treating me more seriously now. I don't even care about your MMRC or your CAT because you're having these exacerbations and because you went to the hospital for your exacerbation, which means it was very bad, okay? In this situation, you can still use your LABA or your LAMA, and then you can add on, right here, add on that inhaled corticosteroid if their eosinophils was greater than 300. So that's what we had talked about, and you saw previously on the slide with the eosinophils. So if their eosinophils are over 100 in your E group, then you can say, I can also give you an inhaled corticosteroid, because this is letting me know that you have a lot of inflammation as well, okay? So you have group A, just a bronchodilator, whichever one you want to pick. Group B, I need to use 2 bronchodilators, they're long acting, both of them. Group E, same exact thing, but now I'm classifying them in group E because they've had an exacerbation, right? They've had at least 2 exacerbations, or they've been to the hospital at least 1 time, okay? And then this was just those key points that we already talked about, right? So rescue for your short acting, you need some immediate relief, immediate response, because I'm telling you I have an exacerbation. I should put on a SABA or a SAMA for that patient. And all of your patients who have COPD should have one of these on board, okay? Because they are likely to have an exacerbation. When they come in for a checkup and you say, hey, how often are you using it? If I'm telling you that I'm using it a whole lot, do you need to do something for me? Yes, I need to be put on what? A LABA or a LAMA, or if I'm already on one, you need to increase my dose of it, okay? Because that means I'm not managed very well. Your group A, you see that you can do any type of bronchodilator most of the time. It doesn't matter which one you want to do, short, long, just put them on a bronchodilator. Sometimes we will try with a SABA or a SABA or a SAMA. But it just depends on how your patient feels, how bad are their symptoms. But again, we like to use long-acting because they don't have to take them as frequently as if they were to do a short-acting. Short-acting, you're using those more frequently. Our long-acting, remember, are more likely to be used for our maintenance. Then with group B, we're using 2 of those together, and we have no choice but to pick long-acting. Right, so a LABA and a LAMA together, and if we can do a single inhaler, that is better than doing 2 separate inhalers. And then group E, same exact thing, and a combo inhaler is better than a single inhaler. And if their eosinophils are over that 300, I add on my inhaled corticosteroid. What was an important counseling point with my inhaled corticosteroid? Wash out the mouth, wash off the mouthpiece, right? Okay, so challenge question, and then we'll do our break. 65-year-old male, follow up, he smokes his cigarettes, he smoked for 40 years, he has a chronic cough, blah, blah, blah. He's had 1 exacerbation, so this is what we're looking for, right? 1 exacerbation, which was treated over the course of 2 days in a hospital. In addition to a SABA rescue inhaler, which medication is most appropriate for this patient? B, right? What group is he?
D.
Why is he in group E?
Hospital.
He went to the hospital, okay? So you don't need a CAT score, you don't need that MMRC score, doesn't matter. He was so bad, he went to the hospital, okay? All right, we'll take our break, we'll come back and we'll do asthma. So, same drugs that we were talking about with COPD, we're going to talk about them in the use of asthma. So when you're studying this lecture, make sure that you're separating the 2, because there's a couple of drugs that we're going to talk about that we talked about in COPD that we do not use in asthma, okay? So when you're looking at asthma, the big thing that I want you to understand from here is that this is like a hyper response that someone's body is having, and there's reversible obstruction. It's not that long-term like disease progression that we saw with COPD. This is more so like there's something that activated that person's body, and they have this reversible obstruction that can happen when you give them that inhaler that you're going to prescribe them, okay? So that's one of the big hallmarks of this disease. That's all I need you to know. This is just background information about the symptoms of asthma. So just know that it is reversible. This is just showing you again how they can have that bronchospasm and kind of what it looks like. So over here you'll see where that airway, especially during an asthma attack, which is what we typically call them, you'll see where this becomes inflamed and thickened, and then again when I give them that medication, it will get reversed and it will be back open again and not restricted, okay? So this is during an asthma attack what your patient is what they look like. This is also now think about breathing through that straw at that point, right? Instead of breathing through a big straw, right, in our fair kind of drink that we have, or a boba tea kind of drink, right, that big straw, and then take one of the little straws that we stir coffee with and trying to breathe through that. That's what this feels like to them. But when I give them that medication, I should see them open back up. I should see that response. Looking at this is just telling you there's several different symptoms or things that could trigger an asthma attack to occur. So if we try to manage or limit these symptoms, I should see that they're not having as many exacerbations or asthma attacks. Some of these things can't be avoided, especially like when we're talking about exercise, right? We want people to exercise. But if we know that they have exercise-induced bronchospasms, we have medications that we can give them prior to them exercising on the days that they exercise, right? So we can prophylactically treat that bronchospasm that they're gonna have. Different infections that people can have, if they have mold, pets, different things like that, dust mites, all of those things can contribute to someone having an asthma attack. So again, talk to them about cleanliness. You'll see some people who have asthma, especially if it's very bad, they'll have on masks so that they can avoid different allergens and things like that, which will lead to an exacerbation for them. Ta-da! We have the same drugs that we just talked about, beta-2 agonists, but instead of it saying in COPD, it is now in asthma. Same exact mechanism of action, hasn't changed, okay? Adverse effects, same exact one, right? So looking at our tachycardia, looking at the hypokalemia, remembering that the higher that I increase this dose, the more likely I am to see a systemic effect and a systemic response. Watching out for that QT prolongation also. Same exact thing that we talked about before, right? So when we're looking at our bronchospasms, again, we want to pick a SABA. So for anybody who gets diagnosed with asthma, they should have a SABA on board. And then looking at this, make sure that you're asking them again, hey, how often are you having to use this? Because if they're using it very frequently, that may mean that I need to increase my dose of my LABA or my LAMA. If I have an inhaled corticosteroid on board for them, that may mean that those maintenance medications may need to be increased, okay? So you see your albuterol, your levoalbuterol, and now you see that you have formoterol, salmeterol. We see two medications that have dropped off now that we use in COPD, okay? So the big difference in between the two. You do see here when we're talking about our two long-acting that we have, our salmeterol and our formoterol. Our salmeterol is a lot quicker of an onset than us looking at our formoterol, but we still don't use it as a rescue inhaler, okay? We still don't use it as if it were a SABA, even though it does have a pretty quick onset. So just make sure that you don't compare that duration of action and think, hey, because it does come on so quickly, I can use this to rescue my patient. No. And that's why we have that black box warning for the increased risk of those asthma-related deaths. We were using a SABA. So, medications that we have, again, salmeterol or your Ceravent discus, and then your formoterol or your Floridil. Don't worry about the dose here. Just understand I have two different ways I can give it, right? An inhaler or a nebulizer. If I give somebody the nebules, what do I need to also make sure I write a prescription for? The nebulizer machine, okay? They have to have the nebulizer machine if you're prescribing nebules. And then pay attention to your comments over here, right? So that quick onset that you can see when we're talking about asthma, but we're still not using this for exacerbation. Looking at the fact that, hey, I do have some rapid onset with that formoterol as well, but again, not using this for an exacerbation. And then your COPD, make sure that you're not picking these for your patients who have asthma, okay? Your indacterol and your aformoterol are not for asthma. Okay, corticosteroids. Same things that we were talking about before. Remember we said that whenever they have an asthma attack that they have inflammation, right? And that's a big thing that when we're talking about asthma. So what we've seen with this is that when we give our inhaled corticosteroids, we see a reversal in that remodeling that some of our patients may experience. So that's a great thing that we love to use these corticosteroids for. We have different clinical uses, and it also depends on the formulation in which we use this medication, right? So we have inhaled corticosteroids and we have systemic corticosteroids that we can use. So when we're talking about our inhalers, Essentially what we're wanting to do with these is have those on board to reduce the need of us going to systemic oral steroids. When we go to our oral or systemic steroids, that's called a burst. We'll give them to them for up to 10 days. It depends on how bad their exacerbation is. Sometimes if the patient is very bad, we will treat their exacerbation in the hospital, because some people do have asthma attacks to where they end up hospitalized, or we can give them these steroids and they can treat themselves at home with this burst, with the steroid burst. So again, it just depends on what's going on. Understand that if I am giving them an oral steroid, one, they're probably pretty bad, and two, that I'm expecting to see quick results from me giving them that oral steroid. So when I say oral, I mean systemic. It'll be like a tablet or an IV solution type of formulation that we can give them, versus my inhaled corticosteroid. That's going to be like a pump, like my asthma pump. Okay. When I'm looking at this, again, remember that these are first line, my inhaled versus me using my systemic, and you can kind of think about this as, hey, if I have an issue in my lungs and I'm giving them this version of it in inhaled formulation, it's going to get to that site quicker, which is why it's first line, versus me giving them something that is systemic, that can increase their risk of those systemic side effects that we talk about with our steroids, right? So if you're talking about your systemic or your oral formulations, this is more so for your patient who may be hospitalized. They had a very severe exacerbation. They're not responding to their inhaler. That's whenever you'll see us kind of reach out for these systemic steroids. Also, some people who have very, very severe asthma, you may see them on a oral or systemic steroid as well. Looking at this, these are preferred, right, because we have anti-inflammatory processes. Therefore, we can decrease the amount of remodeling that they're experiencing. We don't want remodeling to happen. It's not good. So we're trying to decrease that. Should not be used alone to treat an exacerbation. Most of the time, we're going to try to still use their inhaler. We're going to try to still use one of those short-acting beta-2 agonists to try to reverse those effects. But we can add on the steroid to get a more improved response. And then looking at your systemic again, you see that I have a pretty quick response. Within an hour to 3 hours, you see that it does take a while for that maximum response to kick in, but we are wanting to see them quickly have a literal deep breath, right? We're wanting to see that exacerbation calm down. Again, this can be inpatient or it can be outpatient on how these exacerbations are treated. So you have your different options that we have. So your PO options are your prednisone, prednisolone that we can use, and then your IV, you have your methylprednisolone. There are several different steroids that can be used. I did not list all of them. These are the more common ones that you're going to see. These are the ones that I'm expecting for you to know about. Also in our kids, this prednisolone is a good option for them because it comes in a solution form. So that way they don't have to worry about if they can swallow a tablet. If we do choose to treat them on an outpatient basis, we can just give them that solution and they just drink it. Here are your inhaled corticosteroid options that you have available. So all of them are listed here. You don't need to remember the different formulations. So what this is essentially saying is there's a 40 microgram per puff and there's a 80 microgram per puff. So there will be several different boxes that we see in the pharmacy, and depending on the strength that you choose to prescribe will be which box we give them, okay? So just understand this is the generic name for the drug, and then your brand, right? And then you have low, medium, and high doses when we're talking about steroids. And you'll see this when we go over our steroid lecture. There's low, medium, and high doses that we have. So when you're talking about a lower dose, this is probably a person who is not that extreme. They're not that severe. They don't have a lot of flares. Their disease is probably like mild to kind of moderate. If I'm over here, this is more severe patients, or those patients who aren't going to be very well controlled, and I need to increase that amount or increase the amount of steroid that they're getting, okay? So instead of saying, hey, I'm going to give you that 40 microgram box, I might give them the 80 microgram box, because if I gave them the 40, I might have to say take 4 to 6 puffs instead of still being able to say, hey, just take 2 puffs, right? So that's how you'll see this kind of being controlled with your low, medium, and high dose. Adverse effects, cough, lose their voice, sore throat. You'll have the thrush, which is why we tell them to rinse out their mouth, rinse off the mouthpiece. You see that you can use that spacer in these patients to make sure that you're decreasing the amount of side effects that they have. But we have several patients who use these inhaled corticosteroids without a spacer. It is not a requirement. It is something that you can do to help decrease the risk of them having that thrush occur to them. So if you had a patient who continuously kept coming in and they were like, hey, I have this the thrush again. Like, all right, you are using this spacer. And you just prescribe them a spacer and we can dispense them from the pharmacy because we have those in there. These are your oral, so pay attention to the difference between the two, right? So this said inhaled, and then these say systemic or your oral steroids that you have available. So you see your prednisone, prednisolone, your methylprednisolone, and then your dexamethasone. These were the ones that I was telling you that we use more often. Your dexamethasone, this one is more so used in the ED sometimes because it has a very long half-life, and they're like, hey, I can give you this one dose and then send you home with the other meds, or I can give you this dose and make sure that you respond well in the hospital before I let you go. Okay, and then the same thing, your methylprednisolone, you have an IV formulation, so of course they're going to have to be in that hospital setting. And then your prednisone and your prednisolone, these are your two options that you have. Your prednisolone is for your kids, right, for your pediatric patients. Because we are typically using these as a burst, which is less than 10 days, most of the time we do not have to taper our patients off of these steroids. So when we talk about steroids, we're going to talk about how you have to taper them off. With these, we don't really worry about that because it's a short burst, right? I'm typically giving them between 5 and 10 days, and they're on it quickly and they're off of it. So looking at this, you see that we have some conditions that could be worsened if I give them these systemic steroids, which is why I like to try to use my inhaled before I get to that systemic. If I don't need to use my systemic and I have my patient well controlled, I don't have to get to this point to where they're having these serious exacerbations that require these systemic formulations. So if somebody has TB, hypertension, diabetes, remember this can kind of affect all of that osteoporosis because it can further decrease the strength in their bones. I'm worried about all of these things. Does this mean that I can't use it? No, it means that there's more monitoring and I don't want to use it very frequently. Short-term use, long-term use, you've seen these already. These are the same exact side effects that we had on the other slide, so make sure you're short-term. You have that weight gain, you have insomnia that can happen, you have the fluid that can be on them, and then the longer that they're on them, you can see more of that edema happening. You can see a lot of different muscle weakness, Cushing's. We call it like they get like a buffalo hump in their back because like the fat stores start to kind of stay. They have a moon face is what we call it because it's kind of round. So just think about like long-term types of things. We're worried about them. You'll see more bruising and like their skin will start to thin, especially if they're older. So they don't come without side effects, but because we're not using them for a very long period of time, we usually don't see these long-term use side effects, but you can, especially if you're using a higher dose. The higher the dose, the more likely you are to see those long-term uses happen a little bit quickly as well. All right, some of the other medications that we use in asthma. This is now combining my corticosteroid with my LABA. So the same exact thing, just make sure that you understand using these things together helps us a lot with decreasing the symptoms that that patient may have. And I'm going to have better adherence because I have one inhaler instead of trying to give them the inhaled corticosteroid and a LABA. And this was the ones that we said when we use them together, we have a better response. Not to be used to treating our acute symptoms. Why?
Because it's a LABA, not a SABA.
Because it's a LABA, not a SABA or a SAMA, right? And then this black box warning again, make sure that you're remembering that. And then here are all of your products that you have. So this is looking at your steroid portion of it, and this is looking at your LABA portion of it, okay? Your cromolyn, where do we see this? Remember we talked about that mast cell stabilizer and how it takes forever and we don't love it? It's that, okay? So make sure that y'all are keeping track of where we can use these different drugs and how they're kind of coming about. So with this same exact mechanism that we talked about before, But why we like to use this in asthma is also has, again, because it's trying to stabilize that mast cell, it's going to decrease that inflammation that we're seeing, which is a part of the issue that we have in our asthma patients. Not one of our preferred options that we're going to go to, just like it was when we were talking about our other conditions yesterday. The same thing kind of applies here. Looking at your patients that you're using it in. So if they're mild persistent, alternative if they can't tolerate any of your other medications. Looking at this, if you know that you're trying to prevent some type of inflammation from occurring because I'm going to be in contact with a trigger, you could potentially use this here. You can potentially use this when I'm talking about my exercise induced, because again, I'm stabilizing that mast cell so that it doesn't release those mediators that are going to lead to the inflammation. And then you see, hey, I'm not that great whenever I'm comparing this to an inhaled corticosteroid. But if there's a reason why I cannot use that inhaled corticosteroid, that is why you see this as an alternate. This is an alternate. So if you have both of these, this is not what you would pick first, because it is an alternate. Unless there's something that makes you not choose one of your first lines, that's the only time you'll see this being used. Very slow, again, like we talked about. And then you see that we have a nebulizer. So if I have a nebulizer, I need to make sure that I have my machine. Cough, irritation, unpleasant taste, very mild side effects. So it's a very well tolerated medication. Looking at your omalizumab or your Xolair. This one, you probably would not be prescribing this. This would probably be something that is a referral. So let's say they are not responding to a lot of their medications, or if you see that they have that high IgE count whenever you're doing this. These are injections that the patient would be getting. Mechanism of action, binding to that circulating IgE, right, so that I can lower it. And then you also see where it decreases the mast cells from being released again. So like you're trying to prevent that degranulation that's occurring with those mast cells. Clinical use, your patients who have that moderate to severe asthma that we can't control very well, even when we've added on our inhaled corticosteroid. So they're still having a lot of exacerbations, they're still having a lot of asthma attacks. That's where you're going to see this used. Okay, so think about this as like your refractory patients with asthma. That's kind of how you can think about it. Every 2 to 4 weeks, depending on how they respond to the medication, they're going to get their sub-Q shot of their Xolair. Adverse effects, because I'm giving them a shot, you will see that they have pain at that injection site and potentially having some bruising that would go away pretty quickly. And then because it's a mAb, you see where we have that anaphylaxis in our patients who could be getting this. So again, once they have that this injection, we will make them stay around. It depends on the clinic. Some people will do 30 minutes, some people will do an hour, just in case somebody has a late anaphylaxis reaction, and they will observe that patient to make sure they don't need to do anything if they have an allergic reaction to the med. Your leukotriene receptor antagonists. So these medications are very good medications. The one that we see prescribed more often is going to be your montelukast. What it's doing is inhibiting your cysteinoleukotriene receptors, which are part of that that inflammation process. You'll see it also helping with like mucus buildup. If you go back to that mechanism of action chart that we looked at yesterday, you'll see where you see your leukotriene receptor antagonist in there. You have your montelukast or your Singulair, which comes in tablets and granules, like we talked about yesterday, and then you have your Zarfalukast. That one we did not talk about yesterday. With this, make sure that your person is not eating food if you have prescribed your Zarfalukast, which is why we like to kind of use our montelukast a little bit better, because we don't have to worry about the meal situation. So if they do 1 hour before a meal or at least 2 hours after they have their meal, to kind of make sure that that bioavailability is as high as we can get it. Clinical use for our patients who have mild or moderate asthma, and then you can see in our moderate patients that we also will use that inhaled corticosteroid in conjunction with this. Sometimes you'll also see this used in, again, that your patients who have very bad snoring. In your asthma patients, you'll see this also, where they can add this on. For the most part, very well tolerated medication, same adverse effects that you saw before. Make sure that you're remembering that black box warning for your patients, because it has those Neuropsychiatric events that can occur more so with your Montelukast. So if somebody already has psychiatric disturbances, please make sure that you are not going to be adding this medication on for them because you can make them worse, okay? And then those mood disturbances are also something else that can happen with both of these medications, and that suicidal ideation. So again, make sure that you get their background before prescribing the medication. With your Zarfalucas, we have seen in our post-marketing, so that's like our after the drug has come to the market. So when they were doing the studies for it initially, they didn't see this. Now what they're seeing is that people are experiencing a hepatitis, or they will have that hepatic failure that's occurring, which that is what we have found is irreversible. The hepatitis, once we catch it and we note it, we stop the medication, that one is reversible. So just make sure that you're understanding and tell your patient, like, hey, if you start to feel any symptoms, or if you see someone on Zarfalucas and they come in and you have their labs and they have high LFTs, you start to worry for them, okay? You pull them off the medication, and you can switch them to the Montelukast bar and they don't have any contraindications to the Montelukast. All right, our Xylutine. So your Zyflo, this is an oral medication that you have. Make sure that you understand that this one is a leukotriene synthesis inhibitor. So not the same thing that we were just looking at with our leukotriene receptor antagonist, right? Leukotriene synthesis inhibitor. Essentially what you're looking at here is it's inhibiting the production of those leukotrienes from the arachidonic acid, which was again one of those things that was in our mechanism. Here's our picture. Our mechanism that could potentially cause that bronchospasm to occur in my patient, that inflammation to occur in my patient. Second line medication, you see that I can also be using this in my patients who have that mild persistent type asthma, but again, not something that we're going to first line at all. We sometimes will call this our steroid sparing medication to decrease the amount of steroid that we could potentially be giving our patient. You'll see sometimes a provider put this on if they see that those start to creep up, because remember, the higher my steroid dose goes, the more likely I am to see those systemic effects happen. Interactions, watch out for that warfarin, okay, because it increases the effects of my warfarin. Adverse effects, you see the liver enzymes again, and then making sure that you're paying attention to the hepatitis and then the hyperbilirubinemia. Well, contraindications, if they already have very high levels of LFTs, I don't need you to remember the 3 times the upper limit for me, but just remember, if they have elevated LFTs, then we are not going to start this medication because we're worried about those liver side effects that can happen to them, okay? So that's why it's contraindicated. Our anticholinergics, again, see them, same medications that we already talked about, so your tiotropium and ipratropium. Looking here, just make sure that, hey, if my person can't tolerate a SABA, or if they're not responding well to a SABA, I can also try to use my anticholinergic here. When we're looking at this, just make sure that you're understanding your anticholinergics are trying to combat that tone that is being kept, right? Because when we talk about cholinergics, we keep tone. So if I have an anticholinergic, I'm trying to relax that, right? I'm trying to let that person breathe again, okay? Because the constriction is the problem that I have, and I want to open them up. So that's your mechanism of action again that you have there. Clinical uses are all the same things that we talked about before. We like to use these with our beta agonists. Make sure that you're looking at the COPD and the asthma, and when you're using these, make sure that you're looking at when something is an alternative versus when it's a mainstay in treatment. Make sure that you're also paying attention to your products that we use in COPD versus the ones that we are specifically not using when we're talking about asthma. Same anticholinergic effects that we talked about before, so our drying of the mouth, but then I can also, I'm trying to help them breathe, but I can make their wheezing be worse, right? So make sure that you're asking your patient, how do you respond to this medication whenever you take it? Because if they're sensitive to it, you can see this occur. And then this, you see how it's saying, if it's using the ED, you don't have as much of that tachycardia that we talked about with our SABAs. You don't see as much of that if you're using your anticholinergic. Okay, here go our tables that we're going to look at when we're talking about the severity of asthma and how do you know how to treat your patient who has asthma, right? Like, what am I doing to help this person? So, This is our severity chart. If you're looking at your severity, we have intermittent, mild, persistent, moderate, and persistent severe. Okay, so make sure you understand the different classifications that we have, right? Then what I'm looking at is how often do they have their symptoms? Are they waking up at night? Like, how disruptive is this for my patient, right? Is their SABA working? Is it not working? Is it interfering with their daily activity? And then these are what you continue to monitor when your patients come in. Based off of this, you are going to put them on a step 1, step 2, a step 3 or 4, depending on what's going on. And if they're persistent moderate, you can also potentially give them your burst of your steroid, and that's their oral steroid that they're looking at. And then your persistent severe, they're very high on our step chart that you're going to see, so they're at a 5 or 6, and then you can also again see where I could potentially give them a steroid. I want you to remember those things that we just talked about. You're not trying to remember every single thing that's in here, okay? So you swish, swish. It's hard to say swish, swish. Okay? So, you are going to look here and you're going to say, or I'm going to tell you, hey, this person is intermediate, this person is mild, this person is moderate, this person is severe. And you're going to say, oh, they're severe, they're at a step 5 or 6. Oh, they're intermittent, they're at a step 1. Okay? That's what you're looking at. So match the top with the bottom. I will tell you this, you will tell me this. Okay? Don't worry about all the stuff in between. You want to have fun. All right. Now, this is talking about maintenance control. I have put them on a medication, they have come back to me, and I'm trying to say, am I controlling my patient well? Did that regimen, did that step work? Are they still doing the same things to where this medication still works, or do I need to step them up? Do they have too much and I can step them down? What's happening with my patient? So this is your maintenance control. How do you look at your person and say, hey, where do I need to put you now? So I have my well controlled, not well controlled, or very poorly controlled, right? I'm really messing up over here in my very poorly controlled. So if I'm well controlled, keep me where I am, right? You don't need to do anything. Maintain me there, no changes. If I'm not well controlled, you might need to step me up a little bit. So give me a boost, right? So you might need to push me to that second step. So if I was on step 1, you might need to put me to step 2. If I was on step 2, put me to step 3, so on, right? And if I'm very poorly controlled, we really need to help this patient, right? Because they're having flares. So I can give them a burst of my oral, and because they're so far behind, I can do 1 to 2 steps up. Now, because we have changed their regimen, you're going to bring them back in, typically in a couple of weeks, for you to say, hey, let me make sure that this worked, right? Let me make sure that I did what I was supposed to do whenever I changed their dose. And then the same thing, don't worry about what's in between. So if I told you that your person was well controlled, you're going to say keep them where they are. If I told you they were very poorly controlled, you're going to say, cool, you can step them up a step or 2. What am I doing with them? How am I helping them? Okay? Now, this will vary depending on what guideline you're looking at. The guideline that we are looking at is GINA. Okay? When you do Pharm, you might look at a different guideline. So for this exam, we're talking to GINA. Okay? We're listening to me for this exam. So, when you look at this, we have our different steps. So remember when we were looking here, we said how severe is their asthma? Step 1, step 2, we had steps here, right? Those are those steps that you are now seeing here, step 1 through 5, okay? So that's how you initially drop them on their landing point, all right? So this is just telling you that you have 2 different tracks. This is track 1, which is your preferred track that you have, and then this is track 2, where you have, like, this is your alternate track. So when you're looking at track 1, this is for your patient who is like, hey, you think that they're not going to properly adhere to their daily controller medication. So if I'm not adherent to my daily controller medication, then that means that I'm probably going to have more exacerbation, right? So this is kind of like most of where your patients may fall, okay? So step 1 to 2, as needed, they can use their inhaled corticosteroid with formoterol. What was formoterol? LABA, LAMA, SAMA, a LABA, right? So they're using low dose inhaled corticosteroid with their formoterol. That's step 1 and 2. Step 3, I have them on a low dose now, still inhaled corticosteroid with formoterol. The difference is this was as needed. This they're taking on a daily basis. This is now their maintenance inhaler because they're on step 3. Bless you. Step 4, all I've done is I've increased the dose of that same exact thing, that inhaled corticosteroid with their formoterol. Okay? So as they continue to step up, I continue to step up that amount of inhaled corticosteroid that they're getting. Okay? Because as they get more severe, I'm trying to give them more of that inhaler so that I can avoid my oral steroids. And then whenever you look at step 5, this is where you can see where you can add on a LAMA to their treatment. You're likely going to have to refer patients to this once they get to this point. They'll get IgE tested, all of this stuff for us to figure out other underlying issues that could be happening in those patients. So for step 5, all I need you to remember is add on a LAMA and refer. Okay? So these are your patients who they don't like to listen. Okay? And then for their reliever, you see where you will do the low dose inhaled corticosteroid with the formoterol. So essentially, the idea behind this is that you're giving them one thing to continuously use. But they're still going to have a SABA because we still use SABAs. And it depends on what provider you talk to, we still like to have our patients have a SABA. Okay, so this is saying that their reliever that they're going to use is an as-needed low-dose inhaled corticosteroid, which is the same thing they were using PRN, which is the same thing that they started to use on a daily basis in step 3. Okay? But they're still going to have a SABA prescribed to them to be able to use, because sometimes they may not respond to this. All right, for your track 2, these are your people who they might listen. Right? They're going to listen. They're very adherent to medications, and you can know this by like just getting a patient history. And so you're like, oh, okay, you're adherent. That means you probably aren't going to have a lot of exacerbations. So I don't mind if you had it as needed SABA by itself or an inhaled corticosteroid with a SABA, because you're probably not going to be using it very, very often. So step 1, anytime you take that SABA for your relief of your exacerbation, they want you to take that inhaled corticosteroid as well. Step 2, they just have a low dose of their inhaled corticosteroid. Then step 3, they go to the low dose. I'm trying to do it. Low dose, and now you see that LABA is added on there. Okay? Because this one is just your inhaled corticosteroid. Now you see the LABA added on. Step 4, you're at an increased dose. Okay? Medium to high with your inhaled and your LABA. And then step 5 is the same exact thing that you saw before. Right? So you're adding on your LAMA and refer. Okay? Everybody gets a SABA. Alright, and we'll go over this again before the test. We don't talk about this again. I'll give y'all time to kind of digest this and look at what it's talking about. We talked about exercise-induced bronchospasms, right? I have this exercise that I'm doing. You know that I'm doing exercises, and I'm telling you, hey, I'm having an exacerbation every time I work out. And you're like, oh, do you know when you're going to work out, or did you just randomly wake up and say, I'm going to work out? Oh, I know. Cool. Here you go. Here is this inhaler, or here is this medication that we can give you to help decrease the likelihood that you're going to have a bronchospasm when you go to work out, right? So when we look at this, we have different medications that we can use for our patients. Our drug of choice that we're going to talk about is our SABA. We already know what our SABAs are. That's why I was telling you our albuterol is typically what you're going to see used a lot. So before I go exercise, before I get in my car to drive 15 minutes to the gym, I'm going to take my SABA. If I choose to use a LABA for my exercise-induced bronchospasm, not exacerbation, I have 30 minutes, right? It takes a little longer for it to come on board. And this is us talking about our salmeterol. Our formoterol does come on a little bit sooner, but 30 minutes beforehand, I'm going to go ahead and I'm going to give that LABA to the patient. Then I have my leukotriene modifiers that you see, and this is going to be something that they have to take every single day. These are PRN. This is 15 to 30 minutes before I do my workout. My modifier, so if I put somebody on Singular, right, they have to take that every single day. This is not a, oh, I'm going to take it on Monday, Wednesday, Friday when I work out. You have to take it every single day, okay? So that's the difference between those two. Our drug of choice here is going to be our SABA. 23-year-old female with asthma, diagnosed a month ago. She's at stage 1. She's using her inhaler for exacerbations. She's saying that she's having a lot of wheezing. Her FEV is still not fantastic. And so I'm going to tell you that she's not well controlled. Okay? So if she's not well controlled and she's already on stage 1, and let's say she was on her first track, she's using an inhaled corticosteroid and she's using formoterol, how is she using that? As needed, or is she having to use it every day? This question, the way that I'm asking y'all, I'm talking to y'all, I'm not even gonna make y'all try to answer this way, because I'm asking you how I would potentially ask you on an exam. Okay? So she's taking it, you said if she was at step 1, she's taking it as needed, right? Because we're on track 1. And then now, if I said that she wasn't well controlled and you step me up, what am I doing?
2 different steps of it.
I'm only at step 2, right? And it's the same exact thing. So in reality, if you had something like that's why I said I'm not asking like this. In that situation, I could either say, hey, I want to increase the amount of steroid that this person is having and still let her do a PRN to see if that helps her. And then if it doesn't, I would put her in the step 3 category to where she was taking it every single day. Okay? If I have a person who has prescription, do I have to give them, because she has her inhaled corticosteroid, do I have to give her a SABA for her exacerbations, or is she fine because she has her steroid?
SABA. Everybody gets a SABA.
Everybody is getting SABA. What about my patient if they had COPD? Do they need SABA too?
Yes.
Yes. Okay. So when you're looking at this, this is kind of one of those questions where this is how we used to make y'all diagnose and do all the things. So I'm walking you through this way, and we're going to walk through some problems on that chart again before the exam. Like I'm going to show you that chart again, and we're going to keep walking through it and kind of going back to that, because y'all are probably going to see it again. Okay. This is the same way. Again, just cross this out for how this looks, because I will ask you, and I'm going to tell you the same way. But presents to the clinic, diagnosed a month ago. He's not using any medication at all. He's having wheezing and coughing that's occurring. It worsens with exercises. His FEV is at 85% of his personal best. What regimen would we potentially give this person? So he's not taking anything, and he's telling you he's having complications. So at the very least, what does he need?
SABA.
Right? Some albuterol. At the very least, he needs something. Right? So you see a person who is on nothing, and we're telling you, and I would tell you that he's diagnosed with asthma or whatever. If you see a person who has nothing, then that's your hint that they probably need something if we said that they have asthma. Looking at your inhaler technique, this is a website that has, depending on which type of inhaler that you prescribe to your patient, you can give them this site and say, hey, go and you can figure out how your inhaler works. But you should also probably play it in your office if you have enough time after you've worked your patient up to walk through those steps with them. We do talk to them about it in the pharmacy, but it just depends on if that patient wants to, because they can refuse our counseling. Whenever they're talking to you all, sometimes they respect y'all more and say, hey, I'll sit in here and I'll listen to my doctor, right? So they will probably listen to you. So again, this is a great website for you to look at different ways to use those inhalers. This is talking about that HFA inhaler that we had, so just understanding that they need to make sure they remove the cap. We have lots of people who will call us and say, my inhaler is not working. Oh, did you take the plastic piece off of the inhaler? What plastic piece? The big plastic piece that is on the tip of the inhaler. No, I didn't. Okay, remove that and let's try it again, right? Because they don't know. They've never used it, right? So once they remove that, they prime it away from themselves, away from anybody else. Usually we'll tell them like 2 sprays. There's different inhalers that will tell you a different amount of sprays, and that's just to make sure that the medication gets in there. Nobody's holding their head back and going like this, just tell them to make sure that they are taking a deep breath in whenever they press down that canister in the inhaler. So this is like the canister portion of the inhaler. So this is like their medication part, that little metal part. And then you'll see the plastic piece is the piece that they can sometimes wash out, and that's what that cap is attached to, where people forget to take that off, okay? If they don't use it for a long time, then they will need to reprime it. Oh, shoot. Okay, this is the spacer. So this was the thing that I was telling you about where we can use, and we sometimes use it in our inhaled corticosteroids. So you see they take their inhaler, they put it into the other end of the spacer, and then it has a cap on it as well. Make sure that they remove that cap, and then this just allows for them to have that medication suspended in this chamber for a longer period of time to where they can breathe. So if I tell you I have poor eye-hand coordination, spacer. For our younger kids, we have this, but we also have sometimes in the pharmacy spacers with masks. So it goes through this chamber, but instead of this mouthpiece, it has a mask that will fit their face. And then they can put that mask over, and when the parent or the guardian, whoever, does the puff, it'll go through that chamber, and then it'll get inhaled because they have a mask over their face, okay? So I just make sure that they get it in there a little bit better. And then this is just telling you again how to use that spacer. Nobody's turning their head, right? Just do the puff. They continue to just breathe in. Make sure that when they take that breath in from that medication that is in the spacer, they're still trying to take it as a deep breath, and they still need to hold that breath. Okay? So they're holding for at least 10 seconds before they do their next puff. Because more than likely they're going to have 1 to 2 puffs of an inhaler that they're using, so they need to be waiting at least 10 seconds in between those puffs. So 10 seconds of like holding their breath after they took their inhalation of everything that was in there. Don't be huffing in here. And then this is our DPI, right? So this was the one that I was telling you where the medication can come in that capsule, and then whenever they put it in the inhaler, it kind of pops it. But if they're not able to breathe deeply, then that DPI may not be effective for them, right? Because they have to disturb that powder to get it to the lungs. And then we'll start here tomorrow.